Welcome to Supplementary Video 28.4. During this video, we're going to be taking a look at all of the different changes that happen to a woman while she is giving birth. Obviously, it's a very scary and often a very new experience, at least once for a lot of women, and sometimes they can be a little confusing on some of the information that's out there. So, I wanted to talk a little bit about the changes that they can expect. During weeks 7 through 12, most of the hormones that a woman's going to be going through are going to be secreted by that corpus luteum, that CL. And then during weeks 12 to 17, that CL has disintegrated and the placenta is going to be taking over. And you get lots of different estrogens being secreted during this time period. Estrogens are going to be responsible for suppressing follicle stimulating hormone and luteinizing hormone, basically preventing ovulation because you want to maintain a pregnancy instead of getting ready for the next ovulation cycle. You want to; those estrogens are going to promote the growth of the fetus and the maturation of it, and it's going to promote maternal growth to be able to supply nutrients to the fetus. Other hormones, relaxin is going to increase tissue elasticity. It sounds exactly like the name it's named. So that's going to be things like the pubic joint that's going to be loosened to allow for those hips to actually move a little bit, especially on that pubic symphysis, to loosen a little bit and spread during childbirth. Progesterone is another big one. It's also going to be suppressing FSH and LH, and it's going to be inhibiting uterine contractions because you don't want a premature baby, but progesterone will decrease towards the end of the pregnancy, and so that's what's going to allow those uterine contractions to become stronger and for the tissue to become more susceptible to those triggers. I always think of progesterone as being the pregnancy hormone. Human chorionic gonadotropin (HCG) is going to promote the survival of the corpus luteum. You need it to hang around to be able to secrete some certain hormones from that corpus luteum before the placenta takes over. And HCG is also going to stimulate the gonads to secrete testosterone in the male. A few other hormones, thyrotropin will increase your thyroid hormone production. And with an increase in thyroid hormone production, that's going to increase your metabolism in the female. Prolactin will stimulate the growth of mammary glands to be preparing for lactation. We'll do a video on lactation later. Adrenocorticotropic hormone, ACTH, will improve the synthesis of protein within the fetus to be able to build those proteins and thus build a lot of those muscles and tissues and things like that. And parathyroid hormone will stimulate the breakdown of your bones in the mother to make that calcium get moved into your bloodstream and thus become available to the fetus. During the first trimester, they usually say that you'll gain about 1 pound per month, although you actually don't need any extra calories to supply enough energy and nutrients to the fetus. But during the second and third trimester, that 1 pound a month becomes about 1 pound per week, and you're going to need around an extra 300 calories to be able to supply enough energy for what your body is going through and be able to have a healthy pregnancy if all things else are considered normal. Here you can see the breakdown of what each thing contributes to the weight gain that a woman would experience over a pregnancy. So the fetus, by the time it's born, is going to be about 7 to 8 pounds, sometimes bigger, sometimes smaller. The placenta adds 2 to 4 pounds, amniotic fluid 2 to 3 pounds, breast tissue from the mammary glands getting larger, 2 to 3 pounds. The increase in blood, 4 pounds. Fat deposits 3 to 9 pounds. The uterus enlarging will add 2 to 5 pounds. And so overall, that's going to be somewhere between 22 and 36 pounds for a healthy pregnancy. Some other changes you may have heard of morning sickness. It's going to be nausea. It's not just limited to the morning. It can happen at any point during the day. It's thought to be due to hormones, things that may increase your sensitivity to smell, as well as decrease intestinal peristalsis. So your gut is moving slower. And so that's where a lot of that nausea can come in. Usually morning sickness goes away by week 12, though. The pressure of the uterus as the fetus grows upward can push on the stomach. And so some of that stomach acid can get pushed up the esophagus. That's going to cause heartburn. Downward pressure is going to compress the bladder. So it's going to make you feel like you need to pee all the time. And it's also that downward pressure will compress blood vessels that are in that pelvic cavity, which can cause varicose veins because blood is struggling to move through those veins and return back to that inferior vena cava, back to your heart. And so instead, it's starting to pool like in your legs and things like that. During the eighth month, we talked about that progesterone is suppressing FSH and LH and uterine contractions. But during the eighth month, progesterone levels will fall. Those estrogen levels continue to rise. And so your uterus is more sensitive to stimuli telling it to contract. And you can actually sometimes feel these as a very weak or very irregular contraction. Those are known as Braxton Hicks or false labor. Also, as you near childbirth, you're going to have a mucus plug that's been accumulating in the cervix will be expelled. Usually, there's some sort of blood associated with it, and it's usually 1 to 2 days before labor. This is what's called a bloody show. Other things, oxytocin and prostaglandins will be secreted by both the mother and the baby in a positive feedback loop. We've talked about this before. That positive feedback loop, oxytocin will cause contractions, which cause an increase of pressure on the cervix, which cause more oxytocin, which cause more contractions. And so it's kind of a cycle that continues until the child is born. That positive feedback more triggers more. And so that oxytocin will get things started if somebody is induced or they need to be induced for whatever reason. Pitocin is the pharmaceutical version of oxytocin, can be administered, and that's going to get labor started. During labor, so there's the 3 stages of labor. Stage 1, that cervix is going to dilate to 10 centimeters, and it's going to become thinner, which is we call it effacing. Contractions during stage 1 will be about every 3 to 30 minutes and only last 20 to 40 seconds. But by the end of those contractions, they're going to be about 1.5 to 2 minutes, or every 1.5 to 2 minutes, and can last a full minute. So you're getting 30 seconds to a minute of rest in between each contraction. But it is important to get that rest because each contraction is really, really shutting down blood supply. I think when you flex any sort of muscle, you're not getting any oxygen flow to it, even though you're trying to increase blood flow to it. You're basically using anaerobic respiration. And so that's going to reduce oxygen, and it's also going to reduce oxygen flow to the fetus. And so if you don't have any sort of relaxation phase, you're actually going to see a lot of issues with the fetus because it is suffocating. And so, if you're having issues with this, not getting a good enough relaxation phase in between each contraction, vacuum delivery, forceps delivery, or a C-section may be used. About 12% of the time, the amniotic membrane is going to rupture before labor. So that is when a woman's water breaks. Typically, though, that's going to occur at the end of stage 1 because the cervix is so dilated, and you also have the pressure of the fetal head on that amniotic membrane that's eventually going to make it break by the end of stage 1. In addition to things like Pitocin, the membranes can be ruptured to help stimulate the onset of labor. So you can force that water to break. You just kind of poke it and break it. And that water breaking can help stimulate contractions and help get labor going. So a position called occiput, anterior vertex is the most common orientation. So the most common way that you want the baby to come out. It's considered the easiest way to deliver. It's where the baby is going to be. If you think the mother is delivering on her back, typically the baby is facing down or towards the maternal spinal cord, with the posterior skull, the back of their skull, being the first to enter that vaginal canal. Less than 5% of deliveries do occur with a baby in breech position, which is going to be where they're facing up. You have different types of breech positions. So complete breech is where they're going to be face up, their legs are crossed, and the legs are going to be pointed towards the birth canal instead of coming head first. A frank breech is going to be where they are face up, but the legs are still pointed in the direction that they need to be pointed. Pretty much all breech babies are delivered via C-section because there's a lot more issues that you can get with a breech delivery, because you may have one leg come through and one leg gets stuck or things like that. Limbs can get stuck if you don't come head first, and you're also leaving the head for the last, and they need to get that head out so that you have less contractions and less constriction of oxygen during the contractions. It used to be fairly common for episiotomies to be performed by physicians right before childbirth. That's going to be an episiotomy was an incision from the posterior vaginal wall down in the perineum. Basically, they're just trying to make the birth canal larger. It's a lot easier to suture that back together after birth. But research has shown that when you use an episiotomy and use that incision, recovery for the mother is actually more slow, it's more painful, and actually may not be as full. And so instead, now most physicians will allow that perineum to tear naturally, because tearing does occur. You think you got 8-pound baby come through, there's not enough space, and so things are going to tear, and then so it's more difficult for the physician to suture, but it shows that the recovery is shorter and is better for the mother. So if you are in the occipital anterior vertex position, once that head is through, the rest of the body is going to follow very quickly. The physician will aspirate and get the mucus out of the mouth and nose, and the infant will take their first breath. Once they're allowed, once that infant has taken its first breath, you don't need the umbilical cord anymore. So the umbilical cord will be double clamped. That's going to cause it to collapse, and a cut is going to be made in between the two clamps. You move on to stage 3 of labor, which is the delivery of the placenta. The placenta gets delivered because the uterus continues to contract even once the child is out. If it isn't delivered, a physician will either manually pull it out or will surgically remove it. I mentioned this before. If you don't remove that placenta, you get severe blood loss called postpartum hemorrhage, which can occur, and that can be fatal to the mother. So that uterus continues to contract. It's going to expel the placenta, but it also continues to contract beyond that because it's or what's called involution, where the uterus is going to contract to its pre-pregnancy size. It does take a little bit. Breastfeeding helps stimulate that from the oxytocin, that positive feedback loop, continue to stimulate contractions even though the baby is out. Lochia, which starts out as very thick, dark red color and then fades to a thin pink and then to a very watery liquid, will continue to be discharged over the next 2 weeks from the mother. And so that's something to monitor as it progresses. Thick, dark red to a thin pink to a watery. You want to make sure that it is progressing over those next 2 weeks and that it isn't, usually they say, larger than an egg. Which could be, if it's larger than an egg or stays a very thick dark red, that could be an indication of postpartum hemorrhage, and you need to get the mom to the hospital very quickly. So here you can see the stage 1, stage 2, stage 3 delivery here. There's another picture of the expelled placenta. You can see here we have a normal position baby here. The cervix starting out with no dilation, eventually reaching 10 centimeters in dilation. Here's the position here. So they're going to be facing the maternal spinal cord, so facing down, leading with the posterior of the head. Eventually, once the head is through, the rest of the body follows very quickly, and then you get the delivery of the placenta. Okay, so that is a lot of information all on childbirth and the different changes that occur in a woman as she is carrying the child. Obviously, I'm leaving out quite a bit of things. I went very quickly through a lot of things like the hormones. So if you have any questions on those, please make sure you let me know.